Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, Population-Based 20-Year Survival Among 26,736 People Diagnosed with Thin Melanoma in Queensland, Australia, by Adele C. Green and her colleagues. Hello, my name is Dr. Charles Balch, and I am a professor of surgery at the University of Texas Southwestern Medical Center in Dallas, Texas, and I am a surgical oncologist specializing in melanoma. This article, published in the JCO, is a seminal paper about the natural history of melanoma. It reports on the largest series with the longest follow-up of any previous publication in the field. The data is especially unique because it represents a population-based prospective melanoma registry that is more representative of melanoma survival outcome compared to that reported from major melanoma centers that have a more selective referral of higher-risk patients. The Queensland investigators focused on thin melanomas, those which are less than 1.0 millimeters in thickness, which are the most common presentation of melanoma in most parts of the world. They reported a longer-term follow-up with a 96% survival rate at 20 years. While the vast majority of thin melanomas have a low risk of dying, what about those who died of metastatic melanoma? It is vital for physicians evaluating and treating melanoma to know about the small but important group of patients who, in fact, have a much higher risk of harboring metastatic melanoma and eventually dying from their T1 or thin melanoma. Indeed, we can partition T1 melanoma patients into two populations, a low-risk group that can safely be treated very conservatively and with minimal follow-up for recurrence monitoring, and a higher-risk group of T1 melanoma patients who should be considered for more extensive surgery and more intensive follow-up. The Queensland investigators identified different risk strata based upon two major features: tumor thickness, which was associated with a fourfold increased risk of dying when comparing those less than 0.25 millimeters versus those greater than 0.75 millimeter melanomas, and patient age, which was associated with a threefold risk when comparing patients less than 25 years versus those greater than 65 years. They also identified specific melanoma presentations with a higher risk for metastases. These included acrolentiginous melanomas, melanomas located on the scalp or neck, level 4 melanomas, and those with a nodular growth pattern. Thus, they have provided a blueprint that is entirely consistent with the experience at other melanoma centers about the features or characteristics of thin melanomas with an increased risk of harboring metastatic disease. To these criteria, we would also add tumor ulceration and a mitotic rate of equal or greater than 1 per millimeter square as surrogates of a more aggressive primary melanoma with regard to metastatic potential, based upon results from the AJCC melanoma staging database previously published in the JCO. We have demonstrated that an increased mitotic rate, that is, equal or greater than 1 per millimeter square, as a measure of melanoma proliferation, is associated with both an increased risk of nodal metastasis and distant metastasis. Ulceration of the primary melanoma is also a reliable predictor of metastatic disease, although it occurs very infrequently among T1 melanomas. Both of these characteristics are reliable enough that they have been incorporated into the melanoma staging system that defines T1b melanomas with an associated increased risk of metastatic disease. So with all these different clinical and pathological features that are used for predicting metastatic risk in melanoma staging, how does the clinician integrate them into a unified estimate of metastatic risk and ultimately survival? Through the AJCC, we have developed a mathematical predictive model that estimates actuarial survival rates of melanoma patients with any given combination of clinical and pathological features of their melanoma. This predictive model can be accessed at www.melanomaprognosis.org. That's www.melanomaprognosis.org. For example, a 25-year-old with a 0.9 millimeter non-ulcerative melanoma of the extremity has a predicted 10-year survival of 95.9%, whereas a 75-year-old patient with the same characteristics has a predicted 10-year survival rate that is lower at 92.7% if the T1 melanoma is non-ulcerative, and it is even lower at 79.7% if the primary melanoma is ulcerated. So how should we assimilate all this information into treatment planning? I suggest there are two patient settings who should be considered for different treatment plans, one very conservative and one less so, that can be discussed with patients. For those patients with low risk factors, a simple 1 centimeter radial margin of skin excision, not including the underlying fascia, is sufficient and safe, as demonstrated in a randomized surgical trial. Such patients require a complete skin exam and a chest x-ray, but no further workup for recurrences need to be done unless there are clinical symptoms. For patients with more aggressive features of their T1 melanomas, consideration should be given to performing lymphatic mapping and a sentinel node biopsy in addition to a 1 centimeter radial margin of skin excision and a primary closure. If patients are found to have metastases in a sentinel node, then a complete lymphadenectomy should be performed, or alternatively, entry into a clinical trial such as the MSLT2 study led by Dr. Donald Morton at the John Wayne Cancer Institute. These patients would then be reclassified as pathological stage 3A or 3B melanoma, depending upon whether the primary melanoma was ulcerated, and a more extensive workup for metastases should be performed, including CT scans. The follow-up of the higher risk T1 melanomas is problematic, since there is no evidence that aggressive screening identifies patients with occult metastases at an earlier enough time that intervention improves their lifespan. Moreover, our analysis of the timing of metastasis in the small minority of patients have demonstrated that recurrences can occur almost randomly anytime within the first 10 years of follow-up. Therefore, there is no rationale for recurrence monitoring at more frequent interval than yearly. in this group of patients with thin melanomas. The Queensland investigators and the government and private funding sources that support them should be congratulated for creating such a unique and valuable population-based melanoma registry. Their findings are very useful for physicians and patients, both for treatment planning and for counseling. I am Dr. Charles M. Balch. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.